Childbirth embodies a mix of pain, courage, fear, strength, and vulnerability. While it brings new life, the process itself poses a significant threat to women's lives. A recent report by the Integrated African Health Observatory and the World Health Organization shows that despite a global decline, Sub-Saharan Africa shoulders a staggering burden. With 531 deaths per 100,000 live births, the region accounts for over 2/3 of maternal deaths worldwide. Welcome back to Africa Science Focus, the weekly science and development show from SciDevNet. I'm Ogechi Kianyao. In continued celebration of the International Women's Month, this week in our Science Explained series, our reporter Busola Ajibola explored the issue of maternal mortality and its impact on the African continent. Maternal mortality is a serious public health concern in Sub-Saharan Africa, with countries like South Sudan, Chad, and Nigeria each reporting more than 1,000 deaths per 100,000 live births, according to the World Health Organization. Dr. Eli Sukarime, Associate Professor and Consultant Obstetrics and Gynecologist at the Rivers State University and Teaching Hospital in Nigeria, joins us to explain maternal mortality and the ambitious WHO target to reduce it to less than 70 deaths per 100,000 live births by 2030.
Okay, maternal mortality or the death of a woman in pregnancy within 42 days of being pregnant, or as a result of direct or aggravation of the pregnancy, irrespective of the site and duration of the pregnancy, but not due to accidental or incidental causes. That is the WHO definition of maternal mortality. So if the pregnancy is 2 months or 1 month or ectopic pregnancy, it is all maternal mortality. But if a woman happens to die suddenly during accidents, it is counted out of maternal mortality. Maternal mortality is a tragedy, and the world has put a peg to reduce maternal mortality by 70 per 100,000 live births. But unfortunately, maternal mortality keeps on rising, especially in Nigeria. In some parts of Nigeria, it's over 1,000 per 100,000 live births. And I was quite shocked that one of the data that was being presented in the West African College of Surgeons highlighted that Nigeria is now contributing about 23% of maternal mortality. India is 15%, and other Sub-Saharan Africa contribute about 69%. Because in 2008, when we started the foundation, maternal mortality was 10%. Nigeria contributes 2% of world population and 10% of maternal mortality. After some years, the figure was now 13%. But last week, the data showed that Nigeria is contributing 23%. It's quite unfortunate. The direct causes of maternal mortality are mainly preventable. Maybe that's the next step that you will ask. But I think there are some things to learn. I shouldn't go to the next stage. There are some things we can learn from other African countries, Tanzania, Sierra Leone, what they are doing that we need to learn from. But basically, it's in this on poverty, ignorance, and illiteracy.
Thank you so much, Doctor. So you think that the main causes for maternal mortality are ignorance, poverty, and illiteracy?
Well, those are the causes, but we have direct causes of maternal mortality and indirect causes. The direct causes are hemorrhage, bleeding, contributes to about 27%. Hypertension in pregnancy, 14%. Infections and sepsis after delivery, preparatory sepsis, a good number of percentage. Then we also have complication of labor dystonia, that is labor that is not progressive. And a patient that added thromboembolism, women will just stay and throw emboli and pass away. Those are the direct causes of maternal mortality. Indirect causes, we have malaria in pregnancy, anemia in pregnancy, heart disease in pregnancy, and a host of all of them. HIV in pregnancy are the indirect causes of maternal mortality.
The World Health Organization aims to reduce the global maternal mortality burden to less than 70 deaths per 100,000 live births by 2030. And to achieve this, Africa needs to witness an annual reduction of over 20% in maternal mortality ratio from 2020 onwards. Understanding the pattern and burden of maternal deaths in sub-Saharan African countries is crucial to devising effective health programs and policies to address this public health concern. Osaretin Okonji, a doctoral researcher at the School of Pharmacy in the University of Western Cape, South Africa, has been studying the pattern of maternal mortality in sub-Saharan Africa and shares her findings with us.
So our study found that the pattern of death vary across different countries. So like, for example, we found that in countries like Senegal, Comoros, Rwanda, Mauritania, Sao Tome and Principe, Gambia and Ethiopia had the lowest adult female mortality rate. On the other hand, we found that countries like Chad, Niger Republic, the Democratic Republic of Congo, Nigeria, Mauritania, Senegal, they had reported highest female deaths that are pregnancy related. And Chad had the highest at 44.7%. We also found that overall, we found Lesotho, Liberia, Chad, DRC, Sierra Leone, and Guinea. And these countries reported leading pregnancy-related mortality ratio, the highest per 100,000 live births. So we found the pattern of death vary across different countries in Sub-Saharan Africa. So some countries had low and some countries had high mortality rate.
One thing that stood out in your study was that in some countries we have women who are younger,
Yes.
dying more. Can you please elaborate on that findings?
Okay, that was one of the findings we found. We found that younger women were dying in some countries then compared to other countries, and women younger than 30 years old had higher prevalence of pregnancy-related deaths than women who were 30 years and above. So this pattern, though, was not consistent across countries. It's not consistent. We only found that some women, younger women, were dying compared to other countries where women 30 years and above were dying. So, but it's a well-known fact that women over 30 years have higher risks of maternal deaths compared to younger women. So, with the low mortality rate among younger women is at 30 years in some countries could be attributed to data limitation. So, because we didn't have enough data, so that's why we cannot just we cannot accept that fact, but we decided to highlight it in our study. So we think maybe we know that women less than 30 years are dying, because other studies have also reported that. So we know that there's underreporting of maternal deaths in some African countries. So we know because our Sub-Saharan don't have a complete reporting systems for women who die, so who are dying. So we know that, but most studies have found that women who are 30 years and above, 30 years above, have higher risks of maternal deaths due to complications like hypertensive conditions. Yes. Complications during pregnancies are most likely related to women who are 30 years, who are older compared to younger women. So younger women are mostly due to abortion, termination of pregnancies, we think. But we didn't go deep because we didn't have data to look at the causes, yes.
Maternal mortality is far higher in lower income countries, and most deaths take place in low-resource areas. 1 in 45 women die from pregnancy-related causes in low-income countries, compared to 1 in 5,400 in higher-income countries. And in Sub-Saharan Africa, the number goes up to 1 in 38, according to the World Health Organization. The burden of maternal deaths in Sub-Saharan African region underscores the disparity in access to maternal health services. Why does Africa still grapple with such high maternal mortality rates? To shed light on this question, we're going back to Dr. Sukarime, who is the Chief Executive Officer and the founder of Mother, Baby and Adolescent Care Global Foundation.
Some other countries may be carried away by ignorance and culture. For example, in some parts of Africa, they believe that the husband should be present before the woman can deliver or before the woman can be taken for cesarean section. So we should empower our women to be able to take some decisions in critical moments. Signing for yourself during cesarean section. Those are the little things that can be done. We should not tie the woman down to the man. Because if the woman dies, in 6 months' time, that man will marry another woman. So why don't we see if we can help to empower these women? Empower them through education, empower them to be able to take decisions, equity, equality. So those are the little things that we can put in place.
Wow, thank you so much, Doctor. So what you refer to as the direct causes, hemorrhage, hypertension in pregnancy, those direct causes, are they not preventable?
They are all preventable. Majority of them are preventable because bleeding during pregnancy can be prevented. When women are about to embark on the journey of antenatal care, we should build their blood level. Because if a woman enters into pregnancy with shortage of blood, she's likely to lose blood during delivery. Then hypertension in pregnancy, they are predisposing factor to hypertension. Family history of hypertension. A woman that is above 40 or 50 trying to get pregnant, that is stressors that can predispose the woman to high blood pressure. Infection because some women deliver in an unhygienic environment. Deliver with bare hand and instruments that are not sterilized. So after delivery, they are prone to infection. And this can be prevented by hygiene and antibiotics. Then you now go to complications of unsafe abortion. Women that go for unsafe abortion, people that are not qualified to carry out the procedure, or even some people that are qualified but they carry out the procedure in unhygienic environment. Carrying out abortion in someone's parlor is the person may be qualified, but that environment is not hygienic enough to carry out that procedure. So all these things can be prevented.
Thank you, Doctor. While going through the data on maternal mortality in Sub-Saharan Africa, we see that some countries are making progress. And then, that brings me to the question of what do you think those countries that are making progress, that have been able to reduce the rate, maternal mortality ratio rate in their countries, what do you think they are doing right that we need, or the countries that are not doing right need to emulate?
Those things are not high fallopian stuff or not big things. They are little things that can be adopted and that can be copied. For example, in Tanzania, here alone, they have data. They keep data on women that die and the causes of those deaths. And then when they look at those data, they can actually, okay, let us put 1 and 2 in place to prevent more women from dying. Then they also try to make it a law that deliveries should be taken by those that are qualified. The WHO termed them as skilled bed attendants. So I don't like using the word quack, but they don't patronize those that are not competent to carry out delivery. They also try as much as possible to carry out intervention. I was looking at some of those measures that Ghanaian government were copying from Rwanda. Hemorrhage is a common cause. Bleeding after delivery is a common cause of maternal mortality. So what they do in Rwanda is that those drones, they put blood in the drone and fly there to the hospital when the woman is bleeding. And those drones can take 5 to 10 minutes to get to the hospital. So Ghanaian government went to Rwanda to learn that kind of measure. Nigeria, we didn't send anybody. So Ghana is leased from Rwanda, and they are trying as much as possible to use that technology to bring down the rate of maternal mortality. So there are things that can be adopted and adapted. And those things are simple things. Putting data, taking a record of what causes maternal death and try to bring about intervention.
The prevalence of maternal mortality in Africa means there's an urgent need for a transformation in access to sexual and reproductive health care through policy changes and governmental interventions. These were among the findings and recommendations from Osaretin's study as she studies the implication of her research for policy formulation.
From our study, we drew a conclusion that it's good to look at policy to revise policies in Nigeria. But we didn't talk about Nigeria because we're looking at general, Sub-Saharan. So we're not specific. It's not like a specific country, but general. So like health policies in African countries, very weak. So we suggested that health policies is something that the government should look into. They need to revise the policy. It's not working. If the health policy is working, and women cannot be dying like this. It's something that they need to look into and start finding ways of how to revise the health policies in each of these countries to see how they can improve maternal health outcomes. So that's one of the things we suggested. So we talked about the persistent variation in maternal deaths in SSA region, which suggests a greater emphasis on improving the quality of care. It shows that the access of care is not there for women. Obstetric care is lacking in many African countries. Emergency obstetric care is not there. It's not functioning properly. Because if it's functioning properly, women cannot be dying. You can imagine in SSA, over 543 out of 1,000 live births.
I want you to speak to how data constituted a major challenge to your own research and how we can generally use data. How can we improve on data that helps us to understand the challenges that surrounds maternal mortality in Sub-Saharan Africa better?
Yes, I think government has a lot to do. Government has a lot to do. Like most countries where you see that maternal mortality ratio has reduced a lot, they collect data. Because data is what informs you what is going on, tells you what is actually going on in the country. But where a situation whereby data is not collected from every healthcare facilities, you don't have data, so you don't really know exactly what is actually going on. So you get very poor data, and you cannot be able to say, oh, this is what is actually going on. So I think African countries need to do a lot when it comes to data reporting. That's where we are backward. We are far, far backward. We can't compare ourselves with high-income countries. Even other low and middle-income countries are doing well in terms of capturing data, collecting data. South Africa is doing well now when it comes to collecting data. But we, other African countries, we are not taking that serious. We don't see it as anything important. We don't know that data informs us on what to do. Because when there's data, when researchers look at this data, they're able to find out where the problem is, what can be done, as suggestions and interventions can come up like that.
Any idea about how this data should be collected? Any suggestions?
Yes, and they should put systems in place. And this has to do with funding. You have to fund healthcare systems. For putting systems in place require money. You have to put systems in place whereby when people come to health facilities, there are records. They record everything going on. Everything should be on records. That's what people do. In high-income countries, even in some low-middle-income countries, they record everything. So everything should be on records. Like, okay, this woman came to the clinic and she has this condition, she delivered safely, she went home. Everything written, the doctor's reports, important aspects should be captured, as safe as data. And people can easily access it. People can easily access the data. So when a situation whereby data is not being captured, so you actually don't know what is going on. So there's underreporting of many things going on, Just important factors. You don't need to capture everything. You don't need to capture the doctor's notes. Just important data related to patients, like patients' characteristics and all of that, disease characteristics and all of that. So those are important things that I think government needs to do in SSA countries to improve health outcomes for women?
Access to antenatal care is key to reducing maternal mortality. Dr. Sukarime elaborates on the role of antenatal care in improving maternal and child health.
Antenatal care is a specialized care that gives the woman opportunity to assess, be educated about pregnancy, prevention of complications, to enable the woman carry her baby to term. Term is 9 months, to ensure that she has a successful delivery to a contented mother. So antenatal care will help to fish out those that are at risk of hypertension, at risk of diabetic mellitus, at risk of some infection that may not be detected prior to pregnancy. Heart diseases in pregnancy is a vital part of reproductive health that helps to reduce incidence of maternal mortality and also perinatal mortality. So it is very important aspect of reproductive health. And I recommend that if not making antenatal care free, it should be subsidized so that women can gain access to that care.
How do you think the functionality or the non-functional functionality of the health centers contribute to maternal mortality rates?
Well, unfortunately, the primary health care, which was declared in 1978, Alma Ata Declaration, should have been the bedrock to addressing a lot of health issues, including maternal mortality. But unfortunately, there had been a shift, a paradigm shift to the secondary and to the tertiary healthcare. Therefore, at our primary healthcare, we have a lot of those problems, maternal problems, reproductive health care problems, should have been addressed, have been neglected. For example, at the primary healthcare, some problems like malaria in pregnancy could have been addressed and treated, even by the general doctor. But having missed that, there has been a piling of all those problems and pushing them up to tertiary healthcare, secondary and tertiary healthcare. And the tertiary healthcare are minimal. They cannot be able to meet up with the challenges of Nigeria in quotes, with over 144 local government areas in the country. Those local government areas should have been addressed by the primary health care. So having missed up those problems, the maternal care, access to family planning should have been addressed at that level. Now, most of those problems are pushed up to the tertiary health care. And at the tertiary health care, you have specialists who should have been addressed, attending to more serious problems, like problems with gynecological cancers, problems with trying to do research on IVF. And when these problems are so much, the demand will be so much, and many of those problems will not be able to be catered for. And at that point, many women will not be able to be attended to, and the gap will be wide. And if the gap will be wide, that means that many of the women will go into morbidity and then mortality. So the primary health care is key in addressing the problems of women at the minimal level, at the level that intervention can be done and prevented.
Dr. Sukarime spoke about the specific health services that need to be improved to reduce maternal mortality rates.
At the level of the primary health care level, there are opportunities to train not just doctors, but to train community health workers to train those that can be an adjunct especially to the gynecology. And one of the goals of universal health coverage is, as much as possible, to cover areas to bridge the gap between those that cannot be able to access tertiary level care. So it's important to carry along people that may not be able to have enough money to pay out of their pocket. So they can have a pool in which they can put in their money as an insurance, and when it's time for treatment, they can be able to access that fund to treat them, access that fund to be able to get services, family planning, especially child spacing. Because in tropical Africa, in Sub-Saharan Africa, the problems of family size is a big problem. So at that level, they will be able to access family planning services and space their children. So it is vital with respect to sexual and reproductive health. And at that level, they will be able to educate them about the right to accessing health, the right to make them understand that equity and equality is important to the girl child. The right to tell them that having children at the teenage age is dangerous, because at that age, their pelvics are not well formed. So they are at risk of prolonged labor, at risk of cesarean sections. So at that stage, it's important to educate them that education is important. Education is power. And that a lot of these challenges of reproductive health diseases, HIV, hepatitis, can be prevented. Because when a girl child contacts these diseases, they are most likely to drop out of school, and they are most likely to have morbidity. And if care is not taken, the morbidity can lead to maternal mortality.
Can you speak to technological innovations that we can leverage to reduce maternal mortality in Sub-Saharan Africa?
At presently, there are some drugs, there are some researches that are being used to address some of the problems of elevated blood pressure. For example, we advocate for magnesium sulfate. Magnesium sulfate is a drug that can be used to prevent seizures, convulsions during pregnancy, especially with those that have elevated blood pressure. That is on blood pressure. And also the researches are ongoing that commencing women with low dose aspirin can also help to reduce the incidence of elevated blood pressure. So those are little things that can be assessed and affordable. And also the area of hemorrhage and blood transfusion. There are some supplements that have been instituted that help to build up the woman's blood, especially those that have shortage of blood, so that by the time they deliver, they may not be predisposed to bleeding. And of course, if not controlled, can also lead to maternal mortality.
That's all from us at Science Explained today. If you want to find out more, head to the SciDevNet website. That's www.scidev.net. Today's show was produced by Alice Hurst, with editing by Ogechi Kianyao and Titilope Fadere, and hosting by me, Ogechi Kianyao. Today's reporter was Busola Ajibola. Until next time, goodbye. Africa Science Focus is produced by SciDevNet and distributed in association with a local radio station.